on to our last telemedicine to inform primary care practice during SARS-CoV or TIPPS echo. This particular echo was part of a one-year supplement to a geriatric workforce enhancement program grant from HRSA. And that's why it's just going for 1 year, because it's specifically related to challenges with telehealth and COVID. So our GWEP is based at Northeast Ohio Medical University in Ritztown, Ohio. And our GWEP is a collaboration with numerous academic, healthcare, and community providers. My name's Sue Hazlett, and I'll be your facilitator for this echo. The title of today's echo is Mental Health, and our presenter is Dr. Jan Lindsay. Dr. Lindsay is an associate professor at Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. She's a research psychologist and an investigator at the Veteran Affairs Health Services Research and Development Center of Excellence. So she will be speaking in just a minute. Just some housekeeping things. Keep in mind that the format for the echoes consists of an introductory didactic, which Dr. Lindsay will be presenting, and that'll be followed by an interactive case presentation and discussion between frontline providers in our expert panel and you all. Today's case is going to be presented by Sue Fosnight. Before we begin, I'd like to introduce the faculty for our TIPPS echo. And I'm going to call on them if they would just introduce themselves. Margie?
Hi, I'm Margie Sanders. I'm the project director, and I am from Janet. It's nice to meet you. Hi, I'm from Neomed. Thank you.
Good to see you.
Denise?
Hi, I'm Denise Kropp. I'm the data manager as well as the echo coordinator for our GWEP's echoes.
Sue?
Hi, I'm Sue Fosnight. I am a pharmacist. I work at SUMA, shared faculty with Neomed. Nice to meet you.
Brandy?
Hello, Brandy Krzyzanowski from Direction Home, Akron-Canton Area Agency on Aging and Disabilities, project manager, and I am also a social worker on the GWEP grant.
Donna? I thought I saw Donna.
I'm here.
There you go.
I just have to unmute myself. Donna Barrett, Summit County Public Health, Senior and Adult Services. I'm on this grant, and I'm a social worker by trade.
Is Kit with us? That would be Dr. Marquita Belines, physician in the Office of Geriatrics at Neomed. And then is Janet with us?
No, I don't see
And that
Janet
would be-
either.
Okay, so Janet is the supervisor at the student run at Neomed. So almost ready to go. Just a few other housekeeping items before we start. Please mute yourself during the presentation. If you have any questions, if you could, while she's presenting, if you could type them into the chat, and then we'll share them with the group. Please make sure your name shows on the screen, and hopefully your face if possible, just so we can interact a little bit better as a team. After we're done with the case, if you want to just ask your question in person, you can unmute at that point. And just so you're aware, today's case session is being recorded. And also be aware that the details of the case that Sue will be presenting have been changed to ensure patient privacy. So with this, I'm going to turn it over to Dr. Lindsay.
Great to be with you guys. Let me see if I can share screens. And then, can you guys see that okay?
Yes.
Great. All right. So sounds like you guys, I wish I could have joined your other didactics, because it sounds like there's a lot that I could have learned. So I've been working in the realm of telemental health for about a decade, just really integrating technology into mental health treatment in a way that patients and that they want it, right? Because I think a lot of times we as researchers and as clinicians kind of force it. And then pandemic happened and world, everything got a little too real. So just wanting to share with you what we've learned so far in VA. Now, a lot of these data that I'm going to share is kind of preliminary and lessons learned as we move in VA. So as we know, most patients who need mental health care, they don't access it. And those who do access don't actually get an adequate dose. So whether that's psychotherapy or pharmacotherapy, comorbidity and low prevalence, they increase that barrier. So if you have a patient who has OCD and PTSD and hoarding and that getting that specialty care gets even more difficult. Another thing that we know is racial and ethnic minority and rural patients, they experience increased barriers. So some of the benefits that you guys have been learning a lot the last year is reduced barriers to in-person care. So part of what I want to talk about today is how telemedicine and telehealth can be oops, I'm a little echoey, better than in-person care. I'm not sure why I'm echoing.
Do I need to do something to get on the screen?
I think just maybe to mute. Let me do that. Okay. So reduce transportation barriers, travel time. Sometimes they have a lack of comfort. Now I'm going to be talking from the perspective of the VA because that's where these data come from that I thought I would share with you all today. Some patients have physical limitations that make it difficult to come in. What we do know from research is that telehealth is equivalent to in-person care. So effectiveness of treatment, retention in care, satisfaction, cost effectiveness, and increased access. So all of these things are equal to in-person care. Now this research has been going on for about 20 years where we do randomized control studies where we say this group is going to be in person and this person is going to be telemedicine. And then we're going to compare to see if they're roughly equivalent. And research is very clear that it is the same. Now, older adults in telehealth, so older adults tend to have higher rates of comorbidity and chronic conditions. They have most dire outcomes for COVID. So when the pandemic hit, we really focused on how do we decrease the inequity between older veterans and younger veterans. And you'll see from some of the data that it was tough. It was tough, as you guys well know, and I'm interested to hear your experiences over the last year. So this rapid transition to telehealth was very difficult for some people. Technology proficiency, what we call, growing up with technology is different than adopting it later on. There are some physical and cognitive limitations that present additional barriers, so hearing loss. And then, so there are some Bluetooth devices. But honestly, we were caught off guard by the pandemic. And so we weren't always ready to transition everybody into telemedicine. Caregivers were something we learned are so essential, as you all know very well. So trying to do some trainings for these caregivers. In the past, before the pandemic, we used younger relatives and neighbors to try to help. But as we all shut down, we weren't able to really use those creative solutions as much as we did before. So we were really having to work with people in the home that we could get them to get set up with the video pieces, the programs. Now, everybody's using different programs, but Zoom was a popular one, the one we're using today. Caregivers report satisfaction with video visits. So they feel like they are able to show in real time, for example, if you have medication that you want to discuss, go right into the medicine cabinet. So we are able to be creative, especially with the iPads and phones and things where we can move around the house to be helpful. So they do show caregivers themselves getting treatment via telemedicine is also another. So helping them to help the patient, but also the stress of being a caregiver, as you all know, is very real. So these are data that I thought none of this is going to be surprising to this group, but I think it's still compelling that you see right at 55. So here's our younger patients. Now, in the VA, we serve about 2 million veterans a year in mental health. And so this is a big chunk, right? The denominator in this is big. So I think it can be representative of all of our healthcare system. As you see here, this big jump. So as our veterans get older, they're much less likely to use VVC even during the pandemic. So this is the pandemic. Obviously, it's, this isn't an exact date, but you can see the big jump in VA Video Connect. People were not going into treatment. They were staying at home. But the other way they were getting care is phone. And so we'll see that. But this to me is unacceptable as a healthcare. We need to be doing better here. So I wanted, and I'll share this article as well. This is kind of a communications checklist. So when you have a patient and you're uncertain of their technological comfort, you can use this communication checklist to say before we do in the pre-work. So what I don't like for us to do is make any assumptions from the get-go, or just because somebody's not comfortable doesn't mean that we can't help them get comfortable, especially if there are additional resources in your clinic where we can have people being buddies or peers, or again, that caregiver piece. So it's really important to do pre-work. And there are some helpful hints that you guys have all probably been covering over the last several months of your didactic, but speaking slowly, also thinking about other ways of communicating, maybe doing electronic health record before, an email before, setting things up so that you're not doing every single thing over the video. So here is the mental health, and again, large healthcare system. Hopefully it's applicable to you all as well. You see this blue, that's phone visits. And these are older veterans, older patients getting the majority of their care over the phone, audio only. And I think for the first couple of months, we were like, okay, let's get connected, let's just connect. But this is much more intimate than just a phone call. Again, this rural and highly rural and urban. So these are some other considerations, especially for your group to say, before the pandemic, if you were highly rural, you were more likely to get VA Video Connect or telehealth or telemedicine, whatever. But after the pandemic, you see how this switched. So this is that digital divide that we're so worried about. Highly rural veterans are starting to get less, and urban, now we love the growth. Let's just stay on the positive. The growth is enormous, but you see the health, this digital divide, the inequity beginning to happen, flipping from highly rural, people who need it the most, to the least likely here. So prior to COVID, we were really using it to increase access, but it was a choice. It was an option, which is so important. Do you want to come in? People like coming in. They meet their friends for lunch. This was when we compared it to face-to-face. But now that the comparison is simply audio phone to keep everybody safe, we need to be working harder to get veterans, get patients, get people, caregivers more comfortable with this video setup. The time that you spent getting it established, whether that is with clinic staff, we've done peers, we've gone to VFWs and vet centers, again, trying to get a little bit more creative about practicing. So it's not just the session, but maybe practicing with friends and family as well. So consistently high levels of satisfaction when it works. So again, just a little more data to show that rural and older are at risk for this digital divide. And the resources need to be dedicated to that group preemptively, to know that if the older you are and the more rural you are, the more likely you may be to need additional support. And these are just, this is the racial inequities and disparities for us to just be considering. So why is video important? Our team did a study about, do you need to see your provider as a patient? How important is it that you see in the video? Very important. People were saying, yes, there are frustrations. We all recognize there are barriers to this, but just for patients find it very important. And so some of the reasons it's so important is they feel heard, They know that if they're showing emotion, that their provider can see that. Accountability for both parts, that you're not multitasking. You're not, when you truly are present, that person knows that you're not doing all these emails or doing other things. Seeing emotional, felt more of a connection. And it's just better than being a phone. This is a commentary that we did in the Journal of Rural Health that if I'm happy to share and send. Just at the beginning of the pandemic, to push for video. When at all possible, please push for video. And these are the patient voice. Again, just a little nervous at the beginning, but needed a little bit more hand holding. And I can share some real world kind of hints about this pre-work that I think is so important. It's just a game changer. And when those veterans, older veterans, start talking to each other, whether it's at the local VFW or if your patients are at a community center, and when they start spreading the word, there's more, it's more valid when it comes from other patients. Some of the response that the VA has been doing that I think other community centers can also do, working with the phone, the cell companies to say, let's waive the data charges, making making iPads available when, I know this is not always scalable. The other thing I wanted to talk to this group about was these peripherals devices. So things like blood pressure cuffs that you can get on Amazon that are actually Bluetoothed up. A lot of these Bluetooth peripherals, you can begin to slowly integrate into your practice when it's appropriate, so that you can be getting real-time data, or at least teaching that patient how to self-monitor. So maybe the blood pressure cuff isn't on well, and you can show them, with the video component, how to do that correctly. So summary, I know I'm running out of time, just not making assumptions about older adults' tech proficiency. But the most important thing is their interest. So you may have to go about it using some motivational interviewing, some being just a good listener about what are their concerns, engaging peers, and being very patient. But older adults are interested in learning. That's very consistent in the literature. They may not always feel confident or feel practiced, but that should not be a long-standing barrier as we move into the second year of this pandemic. Also inadequate giving simple, clear instructions, things like touchscreens may be easier to use. And then please thinking about ways to train people surrounding your older adult patient and not just that individual themselves. So I wasn't sure, I think there's another case report, but I wanted to share this story, a male rural Native veteran in Vietnam era, living in Oklahoma, went to the Indian Health Service with a 2-month wait, didn't always want to come into the VA hospital. So we sent an iPad to that person. They were able to get evidence-based psychotherapy for PTSD. He reported feeling open and honest. So we also find this with women patients, is that they feel safer and more comfortable in their home, childcare issues and other issues, caregiver issues. There was no commute in the aggravation. And then also this idea of being COVID compliant and people feeling like when they're safe at home, they're able to focus on the work of therapy and not the stress of the pandemic as much. I think that is. I hope that was
so much
and
for that.
relevant.
Oh, very much. So we do have a couple questions. Thank you so much. That was very interesting. Sue Fosnight writes in the chat, do you have more information about iPads via digital divide?
Yes, I do. So I will share. So the VA has, it's called the Digital Divide Consult. And if it's a veteran patient, wherever they're being seen, and this is where I would love to kind of have this ongoing dialogue here, is they can get that iPad sent to their home, or a phone, a smartphone, if they qualify. And it's 4G. And so those patients who don't have Wi-Fi, they can connect to a cellular network. We also have patients though that live in areas where they don't have good cellular connection, and we do a lot of car therapy, honestly, just, get somewhere, drive. And so it opens up, you have to get creative, but it does open up a lot of options for patients. I will be happy to share that information. I'll send it to Martin.
Great. We have a comment from Julie. It says it helps to list the steps to get online for a telehealth visit in a journal or notebook for the client.
Yeah, I totally agree. And I feel like I went quickly over that, but I think, and again, I'm a fan of matching tech with very, just straightforward, write it in a notebook. You don't need to have an app to do this. Like, I think we get a little too cute with the tech stuff and it overwhelms people. Even using things like, oh, have you closed your browser? Well, a lot of people are like, what the heck's a browser? What? Just use regular words. And I also agree with jotting things down by hand or mailing it, snail mail style, that is just more user friendly, because I think when things get amped up with the tech, you lose people that you're trying to reach. By, again, like, well, if you go onto your electronic health record, well, how do I sign up for that? And then you go in this loop-de-loop. And I think we've recognized during COVID, when you're there, everyone's like, well, sign up online for your vaccine. Well, you're required to have an email address. You're required to know how to refresh your browser and all this stuff that I think we need to do better at making it much more simplified for everyone. But when you're starting a tech intervention, to just do one thing at a time. Don't, I mean, my recommendation and what we've learned over time, if you're going to do telemedicine or telehealth, stick with that for a little while instead of doing like an app and a web-based and an electronic health record. Those things are all wonderful in a package, but just recognize that you may lose people along the way if you put those additional tech barriers up.
Any other questions or comments? I just wonder myself how much of what you've had to adapt for COVID is going to stick around. How much is going to be permanent?
No, I think, and I've been in this space for almost integrating tech into healthcare for about 20 years. And I think that, my friends will tease me this, say, oh, I bet you've been waiting. Yeah, we've all been waiting for a pandemic. I worry there's a backlash. I worry that we weren't prepared, and people are frustrated, providers and patients. And I never thought that we should replace in-person care with tech. It should be a complement to augment. And I worry that we're so sick of it that there is going to be a little bit of a backlash. We will be more comfortable with Zoom and integrating this into our lives. But that digital divide that happened, that you could see with the 55 split, that to me is we got to work on that. We got to work on that part. Yeah, some people seamlessly adjusted, but I think the people who needed it the most didn't get it, and they were getting a lot of phone calls, and that is not sufficient. So telehealth and telemedicine. So there's all these terms being thrown around, and kind of digital medicine, digital health. In my mind, telehealth and telemedicine are the synchronous video connection. So it's in real time. And telemedicine has an MD, more medical, whereas telehealth is more so social work. I'm a psychologist, those kinds of things, but they're interchangeable. There is a term asynchronous telehealth and telemedicine, which is kind of electronic health record, apps, things that aren't in real time. Like basically we could all be sitting together in this synchronous way, and we're just trying to replicate that is mine. What staff is able to do this for build? So this has so most telephone visits, audio only, were not reimbursable in the past. And I think they made a good decision for during the pandemic to say, we will reimburse phone only visits. And there's a push to kind of continue that because we recognize that there's a continued need for that. But what I think is telephone visits are just easier and you can do a bunch of different things. And so people were going to get lazy and just kind of say, but you know, some patients cannot do this. Some patients really, they don't have the device, they don't have the bandwidth, they don't have the tolerance. It's okay, but I think a much smaller percentage than is actually receiving phone only care. And so I think that the billable service piece is going to be really important. It's different by state, different by agency. It's just like, they make it so hard for us.
All right, well, if you think of any further questions after the case, we'll keep an eye on that chat box, but if there's nothing right now, let's go ahead and move on to Sue with the with our case.